Thanks so much, Dr. Hiba. Actually, it's softer than it would look like. Okay. So, 17 years back, I got a call from a chairman and the owner of one of the biggest healthcare groups in the Middle East. I went and I met him. I was very happy that I'm starting my career with such a great person. And then he asked me one question. What you're going to do with us? So I told him, as I know your target is to provide care of the highest quality. He said, no, it's not our target. Our target is to get more market share, more profit, more market stability, and more growth. Here comes his question to me. Would you, with the quality or with healthcare quality, help us to reach our goal? I'm Ahmed Safwat. I'm here with you to tell you how I've answered him. I answered him already then, and I'm gonna re-answer again now, through facts only. About 60 years back, in US, they have started their project or their initiative to reach to every American citizen through healthcare coverage. Started in early 60s and continued for about 10 years till early 70s, till they started to say, so why only access? We need to access the communities or the different population with the highest quality through Medicare and Medicaid. But after they started to reach them through the highest quality, they started to suffer it's not coming with the LSD. They started to suffer with the cost. So now they found themselves facing questions, actually two questions. Is it worth it to pay all this money for the quality, to continue with this budgeting problem? Is the quality the ultimate goal, or we have another goal, just to access the highest or the largest amount or the largest number of people in the United States? They told me I should not pass this line. Okay. Today we're here to answer these two questions. And by the way, they are the same questions I've been asked I've mentioned at the start of my talk by the chairman. Today, we're gonna define together, and remember, facts only. What is quality? What is the principles, aims, types? And here I'm talking about applied quality. And I'll borrow the word of Dr. Damati, facts in the area of healthcare business. And then the relation of healthcare quality to patient-centered approach. Then what is the relation between quality and value, and how we can connect it to enterprise risk management? Then can we measure healthcare quality? Do we need to do any kind of change to our behavior or our organizational culture to work in these concepts? Let's start from the start. The start comes with the definition. And actually, the first fact, we do not have hundreds of definitions of quality, as all the time I'm hearing this, we have hundreds of definitions of quality. It's not. This is staged definitions. They started to build on each another. So started by Ahmed Donabedian in 1980, that quality is the ability to achieve the desirable outcome with legitimate means. Okay? Then in 1990, just by Institute of Medicine, they have the same definition, but they have added consistent with the current professional knowledge, which is the evidence-based practice. So here started to appear for the first time in 1990, the definition of quality, it's about evidence-based practice. Then in 1997, by the Council of Europe, they added to avoid the undesirable effects or results. So about safety or risk management. Then in 2010, by the European Commission, they added the last part, and for the first time, response to the needs and preferences of the patients. And here comes the patient-centered care. So actually our definition here comes that we need to achieve desirable outcomes, avoid undesirable outcomes, and according to evidence-based practice, putting into consideration the patient-centered care, values, preferences, and needs. Okay, this is about the definition. So we have the first fact that actually you have a clear one definition. And while we're dealing with quality, all the time, all the models of quality, all the methodologies related to healthcare quality, they are building their approaches on one quality model, which is the original model of Avides Donabedian again, which is consisting of structure, process, outcome. But as qualitician, you need all the time to focus on the process. So what process you need to achieve your desirable outcome according to our definition? And accordingly, what structure you need to do this process or to make this process? So the main orientation here is the process. And the processes in the healthcare system could be technical processes or managerial. And the technical could be the clinical ones, or it can be the non-clinical ones, like the supportive and etc. Structure include the facilities, the equipment, the staffing, and the documents. And the outcome, I'm going to mention it here, and I'm going to mention it again while I'm talking about the value, because actually this is the core fruit of the business. The outcome here, we mean the clinical outcome, including the mortality and morbidity, the quality of life, the function of the patients after he got our treatment. So for example, I have a football player who got a knee surgery. Okay, he can walk after the surgery, but he cannot play football again. So yes, we do not have morbidity, we do not have mortality, but we have a problem with his functionality. Then about satisfaction and patient experience. Is he satisfied or not? This also is considered outcome. Then we'll go to safety instances. And again, we're going to mention safety instances in another two situations in our speech here. So those are the 5 outcomes. All the time, we need to measure to make sure that we are achieving those desirable outcomes according to the definition. So what is different about the healthcare system rather than the other systems? So we need quality or healthcare quality, not the usual quality. We'll find 4 important features for the healthcare system. The first one, that the involvement of the patient mentally and physically is essential. He's essential part of the care. Your patient is the source of family history, past history, present history, medication history. Also, you need to convince him about the required lifestyles, the required medications, how to stick to the medications and to the requirements to get healed. So this is special to the healthcare system. The other thing is related to this point, the other feature, is that this patient has a very little knowledge about what we are doing because it's very technical. That's why customer education or patient education is an essential part of healthcare quality, because you need to educate him to succeed with what you are doing while you are treating him. The third feature is related to the payment. Mostly, not in our country till now, but we are going in this direction, that the source of payment sometimes is not the patient. So we have different activities providing the care and the payment process. So here we need to go not only for the requirements of the patients, but we have the requirement of the payer. The fourth one is related to the complexity and interactions. And actually the healthcare system is considered one of the most well-known complex adaptive systems. This means that at the level of your department, if you have the best physicians, the best equipment, the best place, that doesn't mean at all that you will have the best results. Because it's still here another factor, which is the interaction between these 3 factors. And if we go at the level of the hospital, if you have the best laboratory department and the best ER department and the best OR department, this doesn't mean at all that you will have the best result, because again, it's a matter of the proper integration and interaction between these areas. This is what's called by complex adaptive systems. So now we have finished with the definitions and why the healthcare system is different. So what are the principles or the basic principles of quality? First, I cannot agree more with Dr. Donabedian when he was talking about leadership. Leadership and vision. Leadership starting from the governing body. Leadership doesn't start in the hospitals at the level of CEO. Leadership means we are starting from the governing body, then the CEO, then the C-suites, then going to the department chairman or leaders, then we'll go to the group leaders. Those leaders is the first focus area of healthcare quality. And later on, also in this session, we'll know why they are very important. They are leader of what? But just keep it in your mind for now. Then the second point is related to staff focus. And by the way, staff focus and customer focus and stakeholder focus, in some literatures, they are joining all of them under the customer focus and classifying them to be internal customers and external customers. Why I'm intentionally dividing them to be three here, to show exactly that we should have in our hospital separate plans for each type of these customers. Staff is a very dangerous factor to any hospital. They are the most important asset and resource for any hospital or for any business. So how we recruit them, how we prepare their job descriptions, how we prepare their relations, how we prepare the hierarchy, their hierarchy and chain of commands within the hospitals. This is related to the staff focus, how we develop them, how we appraise them, and when we need to take disciplinary actions. And by the way, this is the second fact. Quality doesn't need no disciplinary action. No, this is not applied quality. You need to have disciplinary action, but you need to know when to use them and how to direct them exactly. You will not be able to have disciplinary action against a staff while you know through analysis that it is system failure. So you need first to exclude system failure before starting to have disciplinary actions to your staff. Customer focus, and here we mean the ultimate customer focus, which is the patients, which is the patient-centered approach. He's an essential part of the care, starting from knowing how to provide the care, till we provide the care, till we're getting the feedback. Because actually the customer is the market. And as we are talking about how to increase our market share, so we need to have more customers or more patients. Stakeholders, and this is part of the complexity and the interactions related to the healthcare systems. Because actually, stakeholders started within the hospital, starting by our doctors, nurses, pharmacists, dentists, and then we'll go to the patients, families, their relatives, and then we'll go to the regulators, the financiers, payers, media, community representatives. All the time, we need to have separate plan for each, which is called communication plan, and some areas, some literature call it a stakeholders analysis and influencing plan, to make sure that all the time we have win-win strategy. Then the fifth feature or the fifth basic principle of healthcare quality is, as I mentioned in the model of Donabedian, that it's process focus. This is the part you have full control on. Sometimes you do not have full control on the outcome, but you can have full control on the process. Then we'll go to guidance via information. Please go away from leading by sense. Make your decisions all the time informed decisions. Build your decisions on information. And here we need to build the plans. What type of information we need? What is the source of information we have? How we get them? How we aggregate them? How we analyze them? And then how to get the insights from them. Information may be related to the facility, may be related to the equipment, may be related to the staff, may be related to the patients, may be related to the organization memory, your indicators from before, your instances from before, your policies, procedures, documents. All those are information. Then, building on what we have said before about the complexity and interaction in the healthcare system, so it's very logic to mention here in the basic principle of healthcare quality, to mention integrated care. So while we are doing our plan or making our plan, we are not making separate lines for different procedures or for different professions. We are thinking of process-related thinking. So in the same process, it's something related, I'm sure you are aware of the clinical pathway. You will find inputs from physicians and inputs to be done by nurses and inputs to be done by the pharmacist or clinical pharmacist, by the patient relation officer, by social worker, by clinical nutritionist. It's multidisciplinary, and you need to have integrated plan of care. It's not that only. Your patients may move from one department to another department within the same hospital. Okay? It's not that only. Your patient may move from one hospital to another hospital, either at the same level of care or in different levels of care. So how to arrange this? How to have the proper referral, proper transfer of care, proper transport, proper feedback and reaction according to the feedback. Then the last but not least, the continual improvement. All the time you need to improve yourself, but actually improvement should be related to targets. And usually targets of continual improvement are related to three categories of targets. Either to improve outcome, or to improve utilization of the resources, I mean the efforts, the time, and the money, or to improve compliance with the regulatory entities. These are the main targets for the continual improvement. So now we're finished with the basic principles. So we have the definitions, we have the basic principles. So what the aim? What we are running for? Actually, according to Institute of Medicine, 2001, they have created 6 aims for healthcare qualities. But here you can find 7. So I'm going to tell you from where came this 7th one. Institute of Medicine mentioned that the aims for quality, and some books are calling them dimensions of quality, starting by safety, so no harm. No harm to the individuals within the healthcare system, including patients, families, visitors, and staff. No harm to the facility itself. No harm to the surrounding community. This is what's meant by safety here. Then the timeliness. And actually timeliness here means reaching the patients within the right time. And here we have 2 very important terms to keep it in our minds. Waiting time and waiting list. And usually both words are very important while you are dealing with 4 services in our healthcare. ER, OR, OBD, and ambulance service. If you are not dealing with waiting time and waiting list while we are dealing with these 4 services, that means that we are not providing these services in the right way. Because here the important aim is timeliness. Then we'll go to effectiveness. And effectiveness here means simply achieving the desirable outcome. For example, if I come to your hospital, do I come to your what I've done? Okay. Do I come to your hospital to do operation or to have my eye operation done? Or I'm coming to be able to see after I'm not able to see? The effectiveness here means that I can see after I'm not able to see. Effectiveness doesn't mean that I'm able to do the operation or to have the operation done to me. Here the aims are done from the perspective of the patient. Just please remember patient-centered approach. Then we'll go to the efficiency. And the efficiency simply, it's the proper utilization of resources. It's not cheaper care. It's not less resources to be used. It is the wise use of the required and justified resources. Not less, not more. Then the 5th aim is equity. And again, this is the 3rd fact here. Equity doesn't mean only that I'm dealing with all patients the same way, the same level, no differences related to socioeconomic level, dealing with different genders the same, dealing with different nationalities the same, males and females, rich and poor. No, it's not like that only. Yes, it's part of the equity required here. But the second important point, which is all that I'm missing here, is the uniform care. That your patient, when comes to your hospital on Fridays, he's supposed to find the same level of care when he comes to your hostels on Mondays, if he needs it. If something can be postponed, it can be postponed. But don't tell me that if he comes in this certain times, he may face a consultant-based management, but when he comes in this certain times, he may face specialist-based management. And then in these times, he will find resident-based management. This is not uniform care. If I am dealing with the patients following certain schools or guidelines, then my colleagues, when I'm handing over him the case, is using different guidelines or clinical practice guidelines or clinical path. This is not uniform care. If I'm using two systems of resuscitation or basic life support, sometimes I found some hospitals using two different systems for basic life support because they have different sources of training, and sometimes they are members in the same team. This is not uniform care. And by the way, you will never get harmony in the work by this way. This is what's actually meant by equity. Then we'll go to patient-centered. Again, we are talking about patient-centered here, because by the way, all the healthcare quality, if you are searching to get value, it should be done from the perspective of the patient again. So what about the seventh dimension? From where it came? This integrated. This was created by WHO in 2018 and added by WHO at 2015 when they started to deal with the 17 SDGs, which was announced by the UN at that time. So they started to say that you will never be able to provide quality care without integration between different services. That's why they have added this integrated care to the dimensions. So do we have different types of healthcare quality? Actually, from the practical point of view, yes. It's not one healthcare quality. We have something we are calling, actually the name refers to the European office of WHO, which was released in 2017, when they call it patient quality. And they meant by this one, the quality which is expected by the patients, perceived by the patients, noticed by the patients when they are there. So the patient can see if you have good waiting area, good way of parking, good accessibility to the hospital, good way of dealing with him or contacting him by physicians and nurses, calling him in the right way, in the proper time, waiting time is not so long, food is good. Okay, this is patient quality. So if they are not there, he's gonna complain. If they are there, he will be happy. This is the patient quality. Then we'll go to the professional quality, and they are a little bit strange, because actually, the patients will never know when they are there, but he will be harmed if they are not there, and he will complain. The best example of it is infection control measures. If you do not have the proper sterilization for your tool, or if you have the proper sterilization for your instruments, the patient will not know, because he's going without infection. He's not gonna come to thank you for that. But when you do not have the proper sterilization for your equipment, he will get surgical site infection, then he will come to complain. So for this part, which is called professional quality, they are there only, they appear only when they disappear. They appear in the complaint of the patient when they disappear from the process. And then the third part is the management quality. It includes all the management issues within the hospital, starting by the hierarchy, strategic planning, operational planning, job descriptions, communication, reporting, assignments, appointments, related policies and procedures to these parts. This is the management quality. And by the way, this part also the patient is not aware of. Let us dig deeper in the patient quality. You will find patient quality includes two types, another subtypes of quality. One of them called content quality. The other one is delivery quality. Content quality means the technical components of the medical care. And here, it's not related to the process. It's related to the outcome. I came to you to see, I'm not able to see. I came to you to see, now I'm able to see. That's it. So what about the staff? How they are dealing with me? How much I'm waiting for the operation? This comes with the delivery quality. It's related to all activities around the technical part. Again, why this categorization? Why this separation? Because there are all the time different plans to deal with these different types and subtypes. So I've repeated patient-centered care 3 times today, and this is the 4th. And actually still another one here, so because it was supposed to be mentioned 5 times. This is the 4th time. What's really meant by patient-centered care? Is it related to satisfaction only? It's related to that the patient is happy of what I'm doing? Actually, it's not. This is the definition of Institute of Medicine. I think it was raised 2004, when they have said that it is the act of providing care that is respectful and responsive. That means we listen and act to individual patients' preferences, needs, and values. And ensuring that patients' values guide all the clinical decisions. They have mentioned all. And let me here mention a story in a 2 minutes time, but it's very important here. I've personally learned from it. It was about 16 years back even, or 17 years back. Actually, by background, I'm a neonatologist. So I got a baby. He is an Indian baby, referring to certain beliefs for his family, that they believe that, and this is what I knew later on, that if their baby received blood from other persons out of their family, he is not their baby at all anymore. And once I have one preterm who needed to have blood transfusion, and I did not have his parent there, I just picked one bag of blood from our blood bank and transfused to the patients, and I rescued the patients, but they just left the baby and left the whole country and went. And they said, this is not our baby anymore. If I know about this at that time, at least I could call them to come to give their baby their blood. Especially, it was compatible. According also to Institute of Medicine, these are the levels of patient-centered care. We have 3 levels of patient-centered care. It is starting by the level of individual patients. So we need to tailor our patients our treatment per patient, yes. Then we have the second level. It is at the service or the program level. When we have different patients referring to the same level of the same service or the same program or the same department, this helped me to tailor the scope and functions and the processes within my department to cope with their needs and their requirements. Then at the hospital level, because these patients may need some services which not in this department only, may be related to the parking, may be related to the information system, may be related to the nutrition, may be related to the lab. So we have the third level, which is related to the hospital level. Then comes to the relation between quality and value. And here we'll talk about 2 important components. The first component is this equation of value. Value here in healthcare quality means the relation between the cost of care and the outcomes of care. You remember the 5 outcomes we were mentioning in the beginning of our talk when I told you that we are going to mention them again? Here. So here we need all the time to measure the 5 outcomes we are talking about: morbidity, mortality, patient experience, safety incidences, and what is the third one? The functionality or the quality of life. And compare them all the time with the cost. Every unit of cost, how much outcome it gives me. This is the real healthcare quality. And by the way, actually we have something that's agreed about, that when you are paying for quality, every single dollar paid for quality should give you $5 profit or saving, or both. If it's not like that, that means you are not spending in the right way. Let me say it that way, spending in the right way regarding healthcare quality. Because sometimes I've met some hospitals owners that they are telling me we are spending more than millions, but no outcome. That means we have something wrong with this equation. And this equation is not separate from the principles, from the dimensions we have mentioned before. The other relation to the value is related to risk management. Because here is the 4th fact we have. Risk management is not related to fire, to disasters, to patient safety issues, to clinical issues only. This is just part of it. Risk management is all about all your clinical administrative system to detect all risks, to assess them, to analyze them, to mitigate them, and to prevent risks. Actually, it includes all these 8 parts, which is called enterprise risk management. Your risk management includes the strategic part, strategic risk. What could affect our image? What could affect our market share? What could affect our reputation? This is a strategic risk. Then the clinical and patient safety. Yes, the patient safety issue. Then operational. What could have our operation stopped if happened? Maybe earthquakes, Maybe revolution, maybe what? Maybe bad weather, maybe problem with our basic infrastructure and utility related to electricity, drainage, etc. Then financial issues, the direct financial losses, human capital. And by the way, human capital risks are related to two different categories. One is related to how to find the proper human capital and how to retain them. But the other category is related how to make sure that no one in your human capital is stronger than your system. Otherwise, your system will be dependent on the presence of this human capital. And this is very risky. This is the weakest system, even if you are gaining huge amount of money, because it may collapse like that if you lost this person. This is a risk. Then the legal and regulatory, it's related to non-compliance with laws, regulations, contracts, and etc. And then technology-related risks, which is related to, for example, the information system hacking, losses, the problem of calibration of some machines, the problem of losing the guarantee of some machines and no spare parts for them, and you have spent a lot of money already on getting them here. And then the hazard, you see, this is the last one I've started when I was talking about it. This is the disasters here. The hazards here mean the disasters and fire and etc. So when we are talking about value here, the enterprise risk management is dealing with keeping the value with proactive actions toward these 8 sources of risks. And as you see, all these 8 sources of risk has direct effect on the financial part of the entity. So if we have all this done, can we measure it? Yes. The measurement of healthcare quality can be done internally, so the entity itself, teams can measure their own quality, or it can be done externally, like regulatory bodies, accrediting bodies, visitors from different entities, so it can be done internally and externally. And by the way, both are using almost the same tools. The first one is related to the surveys, like patient safety surveys, patient safety culture surveys, patient satisfaction surveys, patient experience surveys, staff satisfaction surveys, and etc. Then the indicators. And indicators, most of the time, they are classified either indicator to measure structure, process, outcome, and sometimes they are classified to be operational and indicators, which is a key performance indicators, or strategic indicators, which is the key strategic indicators. Then we have the standards. And believe it or not, if you want to make the best use of accreditation program, use the standards of accreditation internally to assess yourself, to evaluate yourself before others evaluate you. All of I've mentioned will fly like this bird if we don't have robust organization culture. And here, the second time, I'm going to mention the leadership after I mentioned it in the first or the second slide. Because organization culture is composed of the beliefs and values which are established by the leadership and then communicated through different means to reach to all employees to affect their perceptions, understanding, and behavior. So if you want to start to change the culture, please start to change it from there, from the leadership type. We have different models to change culture or to change management. I've just mentioned the simplest one here, the Lewin's change management model. We have Cotter change management model. We have CAP change management model. And every one of them has its own indication to be used. Lewin's actually has a very, very simple concept. That if you have a situation which is not going in the right way or not going well, what you need to do, you need to unphrase the situation, تحلحل النظام, unfreeze the situation, then implement your change, then freeze it again. Actually, it's all about this. Unfreezing the situation, that means you will create the sense of urgency. You will let the people feel that there is something wrong going, there is something wrong happening there. They need to have a change. There is value in this change. This is creation of the change vision, the change need. And then you'll go to implement it, then how to refreeze again. You need to put it in the structure of your system, in your policies, in your procedures, in your contract, in your appraisal, in your indicators, in your monitoring system. So it becomes part of your culture again. And here comes to my take-home message and then take home and go. My answer to that chairman when he asked me about healthcare quality, my answer was yes. Healthcare quality can help you to get more market share, better profit, better stability, and better growth at the organizational level and at the individual level. It will enable your staff to do these 4 things as well. Thank you so much.